Lucy, we're going to go.
Oh, here.
Good. I got it.
To the right.
Yep. Okay. Good. So I'm going to close the afternoon, and we're going to have some questions and answers. But I thought that we would have also a session on just talking about what's coming up in the future and what are the opportunities right now in terms of advancing the science and the treatment. I have three different categories to talk about. Treatments that are newly available. Some of this will be review, but it's good to reinforce things. Some of them you've heard about already, and then I'll kind of close with them. Treatments that we are studying now, and some of you are in research protocols and therefore are joining us in advancing the science and determining whether a new treatment is effective for our patients in the larger sense, so that will be for the future. And then there's some new concepts that I want us to be aware of, that we watch the progress of this in the coming year. So that's those are the three general areas that I want to talk about. So new treatments that are already available, newly available. Well, in the last several months and even overlapping into last year, we have a new monoamine oxidase type B inhibitor called safinamide. There are two older drugs in this category of MAOB inhibition. There's rasagiline. Some of you may be taking rasagiline. There's also selegiline. But safinamide is new, and it is available to prolong the effect of the Sinemet that you may be taking, or Levodopa, to affect and improve motor fluctuations. It is new. It's expensive. But in America, we kind of like what's new, so there's been a great interest in this drug. And there doesn't seem to be any specific advantage of this drug over others, although I have talked with European colleagues with many years of experience, and they feel that there may be, even though it's not approved for this, there may be some improvement in dyskinesia. And one would not expect dyskinesia to improve with selegiline or rasagiline. So if that's the case, it's still too new in America for us to really be able to study that, but that's something to at least consider. Pimavanserin is an agent that is specifically approved for treating hallucinations. This is my area of particular interest in research, and we have not had a drug that the FDA approved specifically for the hallucinations in Parkinson's disease. So this, for me, is a great step forward, and there are other agents that we are currently studying that I'll bring up in just a few minutes. There are new formulations of older drugs that have been on the market for years, but now are reformulated to be perhaps a little bit more convenient or more effective. Specifically, there's long-acting amantadine. Amantadine is a drug from the early part of the history of treating Parkinson's disease, but it's always been a drug that had to be taken multiple times during the day in most cases. Now there are two formulations, one that's taken at night and is approved for dyskinesia, one that's taken in the morning and is approved for improving the duration of effect of the Parkinsonism. So these are agents that could be discussed with your doctor. Of course, anything new is going to be more expensive than the older drug of the amantadine. There's also, and Dr. Verhagen already spoke of this, of the new inhalation levodopa. So many patients, they get good response from their levodopa, but it just doesn't last from dose to dose. And so many patients, they don't know which dose is going to fail them, which dose is going to be short on action. And it doesn't allow then for me to prescribe, we'll take an extra half tab at this dose to prevent it, because every day is a little bit different. This type of inhalation treatment allows one to take the puff when you need it. And so you have to be organized. You have to have it kind of loaded so that when you start to go down, you take this little inhalation, it kicks in quickly and just gets you to the next dose. It doesn't treat the Parkinson by itself. It rescues you to get you to your next dose to treat the Parkinson's. It can be used up to 5 times a day. It does have a side effect that, because it oxidizes, has a chemical reaction with the lungs, it will blacken the nasal secretions and the saliva. And some people find that quite disturbing because it's black. I mean, it's not like a little gray. No, it's black. It's black. It's black. I mean, so you have to sort of know about this and say, could I live with this? Because it's not optional. It's going to happen, all right? So that just has to be, I think, to me, warning, and then you try it and see if it helps. The new approaches that are surgical or in the interventional realm, Dr. Verhagen has reviewed, so let's just reinforce them. The guided ultrasound is coming. It is FDA approved for the essential tremor, which is not the group here, but for patients with Parkinson's disease tremor, it is also approved. But it does destroy, all right? Dr. Verhagen says you get the guided, you get the stereotaxic equipment on it. They measure, they check, they verify, they measure. But once that button is pressed, you can't undo it. You can't turn down the voltage. It's done. It's just plain done. So you say, well, but at least that's easy. It's relatively easy, and the technology is quite advanced, but you don't have all the adjustments and arrangements and follow-up that is seen with the deep brain stimulation. So for people who can't travel, people who can't manage multiple adjustments, this does offer some hope, and we will soon have this, and as Leo said, it will be at the Oak Brook facility. It's not surgical, but it's still invasive, right? That we should not be cavalier about. It's not a drug that you can stop. It's done. There's also interest, and there have been some newspaper articles about spinal stimulation. This is something we're going to be studying in the next year. And this is a spinal cord stimulator, and those of you who did science in college may have remembered the experiments there where cats are stimulated in their spinal cord, and then they start to walk, even though they're totally anesthetized, they can't feel, or they're in coma, right? And they walk because you've stimulated their spinal cord. And many patients with Parkinson's disease freeze. They simply can't walk. Their muscles work, but they cannot walk. And this spinal stimulator is aimed at forcing the nuclei in the spinal cord to start this marching, so you can march. And it's kind of a little bit, say, my goodness, I'm kind of like the Tin Woodsman, that I'll just start walking all by myself. Well, you're not a robot, but this stimulator would induce automatic walking. Something to be studied. The Europeans have studied this more than the Americans. We still have to sort of see and find our own way with this, because I don't want people walking, without any control over where they're going. So there's a lot to be studied in here, but it's quite exciting, and it's a completely different area. It's working at the spinal cord, even though the disease of Parkinson's disease is up in the brain. In terms of treatments in research today, what are we studying with our patients up in the suite? Well, in early Parkinson's disease, we are studying antibodies against synuclein. Synuclein is the protein that when it coagulates or aggregates in the brain, it damages the cells. And the fragments of this synuclein, when they get out of a cell that has died and now is circulating around in the brain, that little fragment of synuclein can get into the next cell and can spread the disease. We know all about this. So what we would like to do is not allow any spread and stop those fragments from ever being able to get into the next cell. And that's where you would think a vaccine should do this. We should be clever enough to do this. And so we have developed antibodies that are now infusions. But if this works, and some of our patients are in this program, if this works, then we would make a much more concentrated form and actually be able to potentially immunize patients with Parkinson's disease today, all of you, so the disease would get no worse. Imagine, because most of my patients say, I don't like what I have, but I could live with this. But I live with the burden of fear about the future. But if we could immunize everybody and say, worry not, we'll treat what you have, but it can't get any worse, that's an enormous gift of science. So we're thinking, we're in this. We have many patients who are in this program, and we will be advancing this program with other agents because there's more than one antibody that could do this. In terms of new treatments for the Parkinson's itself, there's been a presentation about karate and actually what that does in terms of helping patients in terms of their motor control and their balance. There are at-home care strategies that Dr. Fleischer is examining. There's a telemedicine whole program to help patients who cannot come to the medical center. So there are ways that we are outreaching to attend to patients and their needs, even though they might not necessarily be medications. In terms of special problems that patients have, again, I go back to my interest, hallucinations. We are studying a new agent. If there are people in the group here or you know people who are actively having hallucinations, I'm interested in trying to see whether I can recruit your participation to study a new agent that is particularly honed, is really kind of chemically sculpted, that should work in our hallucinators, and I want to see if it works. And so it's got a name. It has a number and a code, but it doesn't even have a name because we're way too early. But if there are people who would like to test this with me, I have openings. There's also a new agent that will be looking for cognitive problems or memory problems. So there's always this active area. And these are all aspects of Parkinson's disease, but not necessarily tremor, slowness, stiffness, balance problems. So the ancillary aspects of the behavior of Parkinson's. There's an issue of non-motor fluctuations. We talked about motor fluctuations where the drug might not last. But there are patients in my practice who, as the medicine is no longer lasting from hour 3 to hour 4, and they still have to wait an hour, not only do they slow down and get more tremor, but a terrible sense of anxiety or doom or darkness descends on their brain. And we are interested in that. We want to treat that as well as the tremor and the slowness. And so Dr. Verhagen has a program specifically looking at this with the intestinal infusion. So there are a number of different kinds of programs looking at not only the motor, but also the non-motor aspects. What should we look for in the coming year? Well, in early Parkinson's disease, I told you about these antibodies, all right? Dr. Hall is leading those programs. We're thinking about neuroinflammation. There's a lot of talk in inflammation in general in medicine, but specifically in the brain. Inflammation in the brain is not a good thing in terms of healing and in terms of stability of chemicals. And Dr. Wittek has a whole program around neuroinflammation. And Dr. Compoliti is looking at new treatment agents that affect energy utilization. How do the subcomponents of the cells in the brain, how do they use the energy that they get? And are those under extra stress because of the Parkinson's disease? Can we relieve that stress? Those are for the early patients who are otherwise not medicated. New treatments for the Parkinson's disease itself. What's coming up? Well, Dr. Fleischer continues with her celebrated karate working, extending more geographically wide, and so going west, going south. Of course, the lake is the east, so we're not going to go there, but with this will be an expanded program. The at-home strategies likewise will be expanding. And Dr. Afshari has a whole program related to telemedicine and specifically doing physical therapy via telemedicine so that people can do exercise and be monitored from home with our supervision. The special problems, I alluded to the hallucinations, the fluctuations. Dr. Barton and Dr. Verhagen are looking at things. There's a new study that is completed now, but we're not quite sure what the FDA is going to do with it, of taking a medicine, the apomorphine that Dr. Verhagen alluded to, but now not as an injection, but instead just under your tongue. So if you start to go downhill, you put a little lozenge under your tongue, perk up, and it gets you to the next dose. These kinds of things are very exciting. There's an agent called accordion levodopa that we've been studying, and then the advanced surgical programs. Finally, there's an issue of gene therapy, of which we now understand that 10% of patients with Parkinson's disease, actually the disease itself is due to a genetic mutation. That's 1 out of 10, but it's still 1 out of 10. And those patients, we know what went wrong. We know exactly what chemical reaction is causing the Parkinson's disease, which is an extraordinary illumination, because if we know the chemical reaction, we should be able to design an agent that inhibits that chemical reaction. That's what chemical engineering is all about, and we're good at that. So now with the definition of some of these agents, and I give you the example of GBA, and we could talk about this at our leisure, but there are forms of Parkinson's disease where now the therapy is aimed specifically at the genetic abnormality, not at dopamine, that's the final common pathway, but at the origin, the actual genetic abnormality. To me, that's enormously exciting and something that wasn't even conceivable in my residency training in my younger generation. So this is very much the next generation. Finally, let us remember that the way Parkinson's disease affects people and the disability and the quality of life, there are aspects that are universal, but there are other aspects that are cultural as well. And the way Parkinson's disease is handled in one country or one culture is maybe different, and there are also racial differences in terms of the genetic makeup. So we have to also be studying this. Dr. Bailey leads that effort in our program. So a wide variety of things for the future. Final, just what is research? Well, we ask in research a clinically pertinent question, a question we think is applicable to you, and we want to design a definitive study. And so we ask our patients, do they want to switch for this program and join a scientific adventure in which there's one goal, and that goal is report accurately. When I see my patients as a doctor and patient, our goal is you get better. But in a research project, it's report accurately. Most treatments have a placebo arm because most patients with Parkinson's disease improve in a clinical trial. It's because dopamine is activated when you anticipate, when you are encouraged, when you are expecting. All those behaviors augment dopamine, and therefore in a clinical trial where you don't know what you're going to receive, there's in fact an improvement in almost all patients, and that's the placebo effect. It's positive clinically, but it is not part of the treatment effect. Patients give their time, they expose themselves to an unproven treatment, but they do gain access to agents otherwise not available, and way much sooner than they would ever be available in the regular clinic. They need to come more often, they keep records, they report to us accurately. So to be a good research candidate, you cannot expect. You can hope, but you can't expect. To be a research candidate, I ask my patients, answer yes to the following questions. Do I want to get better? Of course you want to get better. Do I want to help others? Not everybody. You would wish you'd say yes, but not everybody really feels that. And you have to answer yes to both because you are helping others. So you speak to your doctor, you send your doctor a note in the MyChart, and we can find likely a program of interest to you. For those of you who follow the international advancement of science, I tell you that every year the International Parkinson and Movement Disorders Society has a Congress. It changes throughout the world. This year it is in Nice. It's next month. So your doctors, your faculty will be traveling to Europe for gathering for 1 week all the information about where we stand internationally with Parkinson's disease and research. They will be on the podium. They will be sharing our research from Rush. You are all a participant of that. And that's how we gain the encouragement and the dynamism to take this the next step into the next year. So that's where we stand. And I think, Lucy, I turn this back over to you. Thank you for your attention.
Thank you very much. Does anyone have any cards for questions and answers? We'll step up. I'm going to have someone else come and pick up the questions and index cards, but I think Dr. Paul, Dr. Gatz, and all the speakers today would want me to bring out 3 important people today that I think have done a tremendous job with the workshop, with the symposium, and that is Lauren. Could you come out here, please? these are the faces that you guys do not get to see. Lauren, Lisa, come up here, please. And our fearless leader, Kimberly Parsa, could you please come up here? Thank you very much. And raise your hand for any questions and cards. Thank you. No. No.
Are we ready?
We're going to come up. Yeah.
You can come up here.
Any other questions? Cards?
Let me start. Can I start? Please. Okay. I have a question about CBD oil and marijuana. So, and this is a very frequent question. The answer to this is we don't know. And the dilemma here is that the legislators have placed Parkinson's disease on the approved list for medical marijuana and products, but in Washington, marijuana is illegal. And in order to do a clinical study, we have to be registered in Washington. So until these two agencies get coordinated, we're really blocked from looking at any solid scientific study. But what I can tell you from my own patient experience is that patients who, and they're probably patients, I just saw colleagues who have experience with this, and they could share, but what they have told me is that if they take what the marijuana repository or the dispensary officials give them and tell them, it's way too strong for Parkinson's disease because you're getting medicines that go into the brain already, and this is too strong. And patients feel dopey, patients can fall, and it's not a good activity for them. On the other hand, before we close this, if they dilute it, for instance, the oil seems to be the most popular amongst my patients, and they take their little dropper and then they put 10 extra little drops of olive oil, mix it up, they feel better. They feel more relaxed, they have less tremor, they sleep better, they have less aching. So I'm only sharing, but I remind you that every bottle is a completely different potency. There's no quality control. And so if you get a new bottle and you thought, I've just got it perfect, it's 2 drops to 4 drops or whatever you're going to do, you have to start all over. So it's a uncharted territory. We plan to study this, but we have to get permission to study it, and we have to have one source where we know the potency and the quality control. And that does not exist at the present time. Well, that's a different question, but it still hasn't been specifically studied. And the question was about anxiety. Yeah, how about using the marijuana or the CBD or the THC, whatever it's going to be, any of these products for the anxiety or depressive symptoms associated with Parkinson's disease. Again, these issues have not been extensively studied, and you have to remember that any dosing that would come from another condition is not applicable to Parkinson's disease because we are already exposing you for treating the motoric aspects of Parkinson's disease with agents that outside in the community are not being utilized. So it's a tricky business. My point, be cautious, and if you use it and you discover something, share it with your doctor because we haven't studied it. Leo?
Thank you. First, can you hear me? Wonderful. Thank you for sticking with us for such a long period of time. It's beautiful weather outside, and I was happy to see that my questions are questions that I can answer with just 1 or 2 words. The first question, dry skin. Is this a Parkinson's symptom? Yes, it can be, and there's a treatment for it. It's usually called seborrheic eczema, and your dermatologist can prescribe you some creams and oils that will be taking care of that. Next question, is it okay to get the shingles shots? Yes, it is okay. Is it okay to use cortisone? If that's indicated for whatever your doctor prescribes, it's fine from a Parkinson point of view. Can you be too young for DBS? Well, I am biased. I think DBS is a good thing, so never too young for a good thing. But only if you have the symptoms that are going to be responding to DBS, and if we cannot treat it in a non-invasive manner. So in the other room, there were some videotapes of kids with dystonia that got deep brain stimulation. Generalized dystonia, terrible disorder, no good treatments. And we operate on these kids when they're maybe 10, 12 years old. So it can be done. But the most important part is, what do we want to treat? What are the symptoms that we want to get rid of? And can DBS do that? And that's part of what I do, evaluate patients for those particular questions. Can I do one other one? Mm-hmm. Botulinum toxin for lips sucking in. Worth a try. Lips are tough, though, because you do a lot with your lips. Right? Can anybody name something that you do with your lips? Talk. I heard some kissing. There's a naughty table right there. Yeah. Eating, right? So there's a lot of things that you need very fine lip control, but it's worth a try. A little bit of Botox, very small amount, can help with that dystonia of the lips that can happen as a result of Parkinson's disease. Finally, difference between levodopa and carbidopa levodopa. So levodopa is the active, really the active component. Levodopa is the precursor of dopamine. But if you give levodopa by itself, and that is how we started out in the 50s, you need huge amounts because it gets already converted into dopamine in the peripheral bloodstream, in your blood vessels, before it goes into the brain. And what does it do when you have dopamine running in your blood vessels? You get nauseated. The carbidopa prevents that conversion until the levodopa has made it up into the brain. The carbidopa cannot enter into the brain. It's just structurally not entering. So once the levodopa is in the brain, it gets converted to dopamine, which is exactly what you want, and you don't get nauseated when that happens. All right, so that's the difference. We give the carbidopa to prevent you from getting nauseated and to be able to get away with much lower doses of levodopa because it inhibits the conversion of levodopa into dopamine. I think that is all I have here. Oh, one question for Guion, maybe. Dr. Paul?
Sure, right here.
We have a guest panelist, Dr. Paul. When is genetic testing recommended and how much does it cost?
Yeah, it's a great question. So I think at this point, we don't recommend genetic testing for clinical purposes because we don't have a treatment to offer you based on the genetic testing. However, as part of research, we can do genetic testing and for certain trials, clinical trials, just as Dr. Getz mentioned, for GBA and soon for another genetic form of Parkinson's called LRRK2, we can do some testing for that as part of the enrollment in a clinical trial. So if you're interested in these types of trials, you can ask us in clinic, ask your doctor in clinic, and we can point you in the right direction and do testing as part of the trial. You have to be cautious with things like 23andMe, which are things that you can get testing. I mean, the test results are accurate and valid, but just so you know, they test for 2 genes. They test for GBA and LRRK2. For GBA, there's over 300 variants. 23andMe tests for 1 of the 300. Okay, so for LRRK2, there are several variants, and 23andMe tests for 1 of them. So it's a nice price tag for $99 that you can get, those 2 variants tested for, but it's certainly not comprehensive. So if you're interested in learning more about your disease, I would urge you to discuss it with your neurologist, and then we can work with our genetics team, our genetic counselor, and point you in the right direction and discuss what are the benefits of getting the testing, what are the risks of getting the testing, because once you learn that information, you can't unknow it. So just because you can do it doesn't mean you should. So, but that time may come in the future. Okay.
I have a question that covers both the oral medicines and the Levodopa program, that doctors seem to emphasize that you take Levodopa during the day but not at night. Please explain. The concept, not exclusively that we stop at night, but it is, the Levodopa is a stimulant, and it can be associated with nightmares. When it's dark, people are at risk for developing hallucinations. So we tend to sort of cycle down at nighttime. If people are particularly stiff, then we may give the long-acting, the controlled release form of Levodopa so that they get a low level that lasts several hours. But it is true that we tend to try to downplay the Levodopa exposure during the night. Part of that is also because perhaps you're a little bit more sensitive the next day if you haven't been chronically exposed on just 24-hour basis to the same agent. Oh, you have a question?
A question for you?
No.
Oh. I was going to say the same thing because you mentioned Duopa.
Yeah.
So it's that infusion of Levodopa. It's also approved by the FDA for 16 hours of wakefulness. And then suppose it's you turn it off at nighttime, and that's what we do. In Europe, where this has been on the market much longer, some people do take it throughout the night, perhaps at a reduced rate, because the idea is that if you don't have Parkinson's disease, you create less dopamine in your brain during nighttime as well. So we try to simulate the normal physiological condition. This says that a certain guy by the name of Dr. Verhagen mentioned that the MRI-guided focused ultrasound addresses more symptoms of Parkinson's disease. Which symptoms? So remember I said focused ultrasound is approved now for Parkinson's tremor. And that is in a specific part of the brain called the VIM, the VIM. Just remember that. It has now been explored as research for other symptoms of Parkinson's as well. The tremor not only, but rigidity, the stiffness, and the slowness. Basically all Parkinson motor features. Just like we do DBS for all these features, not just for tremor. But that's not FDA approved yet, and it's a different area in the brain that is currently being investigated. So for now, I can only offer you, and even not now, but next year, we can look at bad tremor and make it a lot better with the focused ultrasound. But the other treatments for other symptoms will be later down the, what's that?
Road.
Down the pike, the road. Good. All right.
I have a question about the synuclein antibodies that I spoke of. And the question is, what stage is this study? How advanced is this study? When we talk about stages of study, we use numbers. A stage 1 study means we're looking at its safety in patients with people without the disease, just safety in the human body. Stage 2 is looking at safety and getting a little bit of information on the positive effects in the target population, in our case, Parkinson's disease. And stage 3 is the large clinical trial, usually hundreds of patients, in order to demonstrate, is this better than placebo? The antibody studies are stage 2, all right? They are target population in patients with Parkinson's disease, but at this point, we're looking at safety. Is this safe? Is it tolerated? And that's why we don't give the injection as a vaccine and say, good luck. No, because that's, you can't undo. We give the infusion every month, and we watch these patients to make sure that they're reacting well, that they're not having any problem. And this will be a long term. After we have enough safety data, then we can go back to the FDA and say, we think we're ready for the stage 3, if in our phase 3, in fact, if we are. So that's how that is in terms of where we stand with the synuclein. Very active, but still looking at safety.
I'm going to interrupt real quickly. There's one car remaining in valet with a gray Mazda. If that owner would like to go down and grab their keys real quick, the valet will be able to leave it in front of the building. So if there's an owner of a gray Mazda who is in valet, if you want to run down real quick.
Okay, and in the interest of time, we'll do one more question, and then the remainder of the questions will be in our newsletter. We'll have the questions and answers there. So
One more?
Well, I have one on side effects of medicines. If the inhalation levodopa helps to get you to the next dose, will it induce dyskinesia? Well, it might, yes. I mean, that's what we would be testing. We're giving more levodopa, and you don't get anything for free. We know that. So, yes, we would have to be cautious about it. That's why in most cases I start with a half dose. A dose is 2 capsules. I instruct my patients to start with just 1 capsule, and let's see how it goes. Another side effect of amantadine. Amantadine is cleared by the kidney, so you must have good kidney function, and you must drink a lot of water if you're going to be on amantadine. Side effects include ankle swelling, an unusual rash that's kind of purple and net-like. It's called livido reticularis. That is not dangerous, but it can be unsightly, especially for women who wear skirts during the summer. Men who wear long trousers during the summer would not be bothered by it, but there are some men with shorts on here, so they would also. And finally, a little bit of mental confusion can occur with amantadine, especially if the dose is not kept low or if the kidney function is not completely normal. I want to thank everybody for attending. Let me turn this back to our chair.
Okay. Thank you so much for spending your Saturday with us. I again want to thank our wonderful staff and all of our faculty without whom this could not have been done. And we look forward to receiving your feedback with your forms, so please turn that in to us. And the remaining questions will be answered in the newsletter, and we'll hopefully see you next year. Thank you.